Hi, good morning, everyone. So we're going to start session 3 today. And so when you're organizing a meeting, the biggest nightmare is you realize there's one topic you forget to cover in the planning process. And that happened to us. We realized that payment model is really important. That wasn't on our agenda. So Michael got a panicking email from me about 2 weeks ago and said, please add payment model into your talk. And Dr. Steinberg graciously agreed to add that and then condense his typically 1 hour talk into 30 minutes so that he's doing 2 topics at one. And Dr. Steinberg, thank you so much for doing that. He's a professor from UCLA.
Thank you, Tina. I hope you don't panic when I go way over on the talk. Anyway, thank you for inviting me. I want to thank the organizers for this opportunity to speak. I found the yesterday's discussions really insightful and provocative. So these are my disclosures. As Tina mentioned, this was the title of my talk, and now this is the title of my talk. So what I'm going to cover today is I'm going to address some of the aspects of the emerging value proposition in healthcare and give you a general, very general overview of the metrics to evaluate value in new technology, and from a number of perspectives, from the scientific community, from patients and payers, as well as the broader society. And if I have any time at the end, I'll talk a little bit about emerging payment models, although I should mention that Justin Beckelman's talk yesterday I found very interesting and forward-looking in this regard. What I will barely mention is the process of technology assessment leading to coverage, what I call the epistemological problem of evidence development for technology. Basically, it's a moving target. We talked about that yesterday. The societal dilemma of ever-rising cost in healthcare, much of which is driven by discovery, including discovery in medical technology. But I will mention the imperative of the need of multiple stakeholders to step up to figure out how to fund evidence development and to show value for medical technology. So first, let me set the stage and ask the question, why does cost matter? This is probably not new to anyone in this audience, but the US per capita healthcare expenditures have been on a constant rise, and although they've mitigated in the past few years, the political conversation around this rise in cost has not changed. And our spending in healthcare per capita is fully twice that of other developed countries, yet with no demonstrable difference in health outcome. And so what did all this extra spending get us? Well, over a recent 10-year period, we got about 10% more office visits, same number of overnight stays in the hospital, approximately 80% more MRI scans, twice the number of CT scans with its associated radiation dose, a doubling of the cost of specialty drugs. 50% of that cost is related to cancer specialty drugs, and that cost is said to quadruple by the end of the decade. And the whipping boy of this conference, a lot more proton facilities. So we're number one in healthcare, right? So here's a comparison of amenable to medical intervention mortality for 16 comparable high-income countries, with the United States being dead last on this list. What else happened in the 10-year period? Well, the adult life expectancy in the United States increased by a year, but that was roughly half of the gains achieved by other OECD countries of 2.2 years. And for a family of 4 with a mean income in the United States, a mean income of $52,000 showed a dramatic increase in the rise of their out-of-pocket contribution for their health care coverage, and also a dramatic rise by the employer's contribution. This increase in out-of-pocket expense for patients is accelerating even more rapidly, and particularly with the changes in health reform. And I'll point out, and I'll remember this out-of-pocket factor, because it's going to be very, very important in how we view value and how we view healthcare in the years to come. So a few years ago, I became interested in the question of what is value in healthcare, and I came across this book by Michael Porter and Elizabeth Steinberg, which was foundational in my understanding of value. And I went and took the course at Harvard Business School. I think it was in the first course, actually. And then last year, we set about asking the question, how does radiation oncology embrace the value proposition? And in this JCO article, we laid out a framework for radiation oncology to address value. Now, you could cross out radiation oncology and substitute any medical specialty, and the precepts that are discussed in this article are just as applicable. I'm going to highlight a few items from this article. So the first question, in economic terms, what is value? In the world outside of medicine, a good value is a desirable product or service that can be purchased at a fair price. The definition varies depending on the social identity, social context, and the person doing the purchasing. It's very much in the eye of the beholder. So the reason I have a Ferrari and an SUV up there is to tell you a little story. Many years ago, I pulled into a gas station with our nanny. Same nanny lives with us. It's 29 years later. Kids have long since left the house. Well, I pull up to this gas station, I see a red Ferrari, and I'm ogling the Ferrari, and Delmy, as she always does, chastises me for saying, "You don't want a car like that. It only has 2 seats, it has no trunk. Where are you going to put your kids, and where are you going to put your wife?" I can tell you that we've had many SUVs over the years, but alas, no Ferrari. Basically, for value for healthcare and value for buying cars in many ways is very much the same. It's in the eye of the beholder. I still like the idea of having a Ferrari, but it's more of an idea. Before we get further into the question of value, let me give you some insights into some challenges that affect all of healthcare in achieving value. Consider for a moment the concept of information asymmetries, as mentioned a bit yesterday. The provider and the patient basically don't possess the same information about the components of care, especially around cost and quality. This alone precludes patients from being what economists call utility maximizers, for them to pick the best possible health care. And in the Adam Smith term, it prevents the invisible hand from influencing and creating a free market in healthcare. Basically, a free market does not exist in healthcare. Now, a payer's response to this situation in the lack of this type of information is basically just to grind on price. Another set of challenges are about misaligned incentives, financial incentives. One example is supplier-induced demand, and we also mentioned this. In our fee-for-service encounter-based payment model, basically what is induced is volume, not quality and not value. When payers cut cost, there is something that economists call a volume effect. Just do more of what you used to do to try to get to the same level of reimbursement. Another misaligned incentive is what's called the principal-agent problem. The principals, the patient, assume that the provider, the doctor, the health system, the agent act in the principal's best interest. However, behavioral economics tell us that the agent will act in their own best interest. The self-referral studies around IMRT by Gene Mitchell and the GAO are considered demonstrations of the principal-agent problem. There are also long-standing cultural attitudes towards cancer care that contribute to the barriers to achieving value in cancer care. Cancer was a sacred cow until recent years, and the dramatic rising costs associated with cancer care, we didn't pay a whole lot of attention to it, particularly those costs in the last 6 months of life, and they were not only happened, those high costs, but they were expected societally. However, if you look at cost of cancer, this article by Elkin and Jama in 2010, not only was healthcare cost rising, cancer care cost was rising fully at twice the rate. Now consider for a moment out-of-pocket expense for cancer patients. Cancer has the highest out-of-pocket expense of all disease entities, and some have estimated that out-of-pocket expense for patients to be as high as $18,000 per patient. We are beginning to realize with the changes in health reform, what we're seeing, for example, in California with Covered California, what people sign up for is the bronze plans with very high deductibles. And we're going to start to see patients with Medicaid and Medicaid-like coverage with demands, with dramatic demands for out-of-pocket expense. And in fact, this is going to become so important that others, Zafar and others from Duke, have described this concept of financial toxicity. And in this study of medical oncology patients, they found that 68% going through treatment, cost of treatment, and the severity of the economic impact, 68% patients cut back on leisure activity, 46% reduced spending on food and clothing, 20% took less than prescribed medications, and 24% did not fill their prescriptions at all. You can see how this could have a negative impact on the patient experience and on clinical outcomes. I should point, however, that probably the largest barrier to achieving value in healthcare is the challenge of determining cost, our costs in the system. We basically don't know our costs in the system. Charges and reimbursement are not our costs. It's very important to understand the difference between actual cost and those notions of charges and reimbursement. And until we solve this problem, and many are working on it, we will have trouble in achieving value. Now, measuring cost is mostly done around the notions of departments, specialties, a procedure type, and it reflects mostly the current financing system. However, cost should be measured around the patient's care cycle, through the entire cycle of care. So that brings us to the value equation. What is value? Simply put, value is expressed by this equation. Value equals health outcomes divided by dollars spent through the entire cycle of care. With regards to measuring outcome, Professor Porter proposed a three-tier system. Tier 1 addressed the traditional outcomes associated with survival. Here you see a head and neck example. Tier 2 deals with outcomes based on things going through treatment times to recovery and disutility of the treatment process. Another head and neck example with examples of return to work and G-tube placement and so on. Tier 3 based values start to ask questions, What beyond basic survival to patients' value, such as sustainability of health and effect of late morbidities? So an example of this third tier is expressed in these two articles of patients who receive multimodality therapy for head and neck cancer, in which 33% and 52% never returned to work after their treatment course. So subjective measures such as those in the third tier, traditionally not well measured or well accepted, are becoming an important part of the value discussion in healthcare. Now, at UCLA, we call this value discussion patient voice. And in this regard, let me show you an example of what we have done at UCLA as it relates to SBRT lung. So we surveyed a bit over 100 patients who had received SBRT lung. 40 of those patients had also received surgical resection and then subsequent SBRT of the lung. We asked patients about their actual experience compared to their original expectations in the value domains of anticipated side effects, convenience, and anticipated treatment anxiety. You can see that generally the patients found that their actual experience was much better than they had anticipated. Next, we asked patients who had previously received surgical resection to compare their SBRT experience with their surgical experience. And in the value domains of recovery from treatment, treatment-related anxiety, stress on the caregiver, and convenience, SBRT basically kind of won hands down in these questions. This stuff may seem obvious to everyone here, but this kind of thing is not generally in the literature, not well known among health policy experts, and not well known among patients either. Now, finally, we asked the question, if they knew that SBRT for the lung was equivalent to the surgical procedure, which would they prefer? As you can see, 90% of patients preferred the SBRT. They called it a dream come true. I wish I never had surgery, and an amazing treatment. So all this begs the question, can we afford this new wave of so-called high-value care that we've been discussing for the last few days? So to jump into who assesses value in the United States, Medicare uses a concept of reasonable and necessary. We heard Mark Hartstein talk a little bit about that yesterday. Health plans use the concept of medical necessity, sometimes as a blunt instrument, as a way of deciding who gets what in healthcare. And of course, there are independent technology assessment groups. I'm going to tell you about one of them. That's CTAF, the California Technology Assessment Forum. It's not new to the scene, but their methodology is very new, and I'm going to show you a glimpse of that methodology. What they have done is they've engaged Steve Pearson's group from Boston, ICER, the Institute for Clinical and Economic Review, and who also staffs a Northeastern sister panel called the New England Comparative Effectiveness Public Advisory Council, or CPAC. Full disclosure, I'm a member of the CTAF panel and participate in its deliberations. So first, CTAF, as well as CPAC, is an independent panel of physicians and lay members. It's funded by a foundation of the Blues, but it's separate from the Blues. And until recently, didn't really discuss much about coverage. It was kind of a rigid kind of evidence evaluation, but it has become much more, and I'll show you what that means. The panel reviews evidence and comparative effectiveness and votes on those items in a context that I'll show you in a minute. The process begins with a systematic evidence review and subsequently uses tools of decision and cost effectiveness analysis to determine its findings. It uses a two-component system to look at, rating system to look at evidence. It looks at comparative net health benefit And then a level of certainty. How certain are we from the evidence we have, does this particular intervention do what it says it's doing? So this matrix further explains the process. The net benefit equals total benefits minus total harms. This is often a very difficult judgment because frequently there are multiple harms and multiple benefits to judge. Certainty judges the consistency in multiple studies in multiple populations, hopefully with large N's and low p-values. Both the level of certainty and net benefits are judgments. They're made by the ICER staff and then reevaluated by CTAF in the deliberation process. After evaluation of the evidence, cost effectiveness is derived by using concepts of incremental costs and incremental effect benefits. And consider this slide to illustrate how this might look. In this upper left-hand corner, a new treatment that is less effective and more costly than control would not be of particularly high value. In this lower right quadrant, a new treatment that would be more effective and less costly would be considered of high value. Things that land in the other quadrants need deliberation. Let's just leave it at that. So is there more to value than just this incremental cost effectiveness? And the answer is absolutely yes. So let me show you the framework. Overall, the structure of the panel process involves a range of decision points that no single threshold is determinate, but allows for incorporation of contextual considerations, uncertainty, and subjective value determinations as well before the panel votes. The overall structure of the panel process involves a range of decision points. One such determination point for the panel addresses the incremental cost per outcomes achieved, utilizing the quality metric. And the CTAF panel uses these definitions of quality of high value care, intermediate value care, and low value care. And this is a whole discussion itself of how one uses quality, but we use the less than $50,000 per quality as the threshold for high value care in the CTAF panel. Another decision point addresses other benefits or disadvantages to the intervention, such as that the particular intervention or treatment maybe requires less visits to the doctor. Yet another point are the contextual considerations that may be legal or ethical issues, but not related to cost, specific discussions not related to cost as well, but may influence the priority of particular use of something. A second component of the ICER process that CTAF uses looks at care value from the perspective of the greater health system. Initially, we started looking as if we were creating policy for Medicaid, what we call Medi-Cal in California, but subsequently we look at it from the broader health system point of view, or imagine a very large, giant ACO at risk for a large population. An early judgment of provisional health system value is based on the potential impact of considered change in care and is used to trigger another process to determine if we need a mechanism to manage the affordability of the new intervention. This is done through a complex set of calculations that are population-based for the intervention, and health plans and health systems do have some methodologies around that about if there's a new intervention and it is really good but really expensive, how do we create those societal balances? We recently had 2 panels. We were going to do 1 but 2 around the hepatitis C drugs in this regard. And that further refined our thought processes around this. And when the cost of these drugs, $80,000 for a cost, with a Medicaid population alone of 5 million people that could get these drugs. That's just Medicaid, not the whole U.S. population. We had to look for methods to basically change the policy discussion and change the political discussion as well. And it did have influence on the cost of the drugs across the United States in a very short period of time. Now finally, and for a few minutes, I'll talk about payment models. Like I said earlier, I found Justin Beckelman's comments yesterday very, very appealing and interesting. But I'll tackle payment models in a kind of an atypical way, possibly. Some of it will look typical, I suppose. First, the change from this encounter-based fee-for-service payment models to a strictly value-based reimbursement model will be an evolutionary process. And some markets will move faster than others, although it should be noted that some markets will not necessarily be isolated from the effects of outlying centers of influence, centers of excellence that will come in and influence the value discussion in a particular community. Now, as I've said before, the fee-for-service encounter-based system basically does not incentivize value, it incentivizes volume. The value-based system, however, one would say, and I think this is more than theory, incentivizes the triple aim of improved patient experience, improved health for populations, and lower per capita costs. So payment model reform models usually look like this type of progressive process seen in this diagram, which represents an increasing aggregation of services into unit payments with associated increasing association with risk in the assumption of care. However, and regrettably, the discussions around medical technology payment models look more like this: prior authorization, case rates, things like that. But I will spend a couple of minutes talking about the guideline and pathway-based management for a moment. Pathways in oncology are seen to be a solution to rising costs in cancer care, and put this in the context of pathways versus guidelines. Guidelines, let's stipulate for a moment that guidelines, because of what they are and how they're put together in a consensus sort of way, often with specialty societies, tend to be very inclusive and have lots and lots of treatment options. Too many. Pathways, on the other hand, are specifically defined process of care. If optimally, they're developed by clinicians in a particular region or community through a consensus-based process, looking at efficacy and cost, patient acceptance and efficiency, local care factors. Here's an example Neubauer article in Journal of Oncology Practice that reported the U.S. oncology experience of using pathways in non-small cell carcinoma of the lung with similar survival with a 30% decrease in cost just by selecting drugs carefully. Jason, in the next talk, will talk about this is a published model as well, about IMRT pathways in the state of Massachusetts. I won't spend more time than that on that. So if you consider this list of potential targets for reducing cost of care for cancer treatment, let me focus for a minute on this notion of equally effective, cheaper treatment alternative. The notion of least costly alternative is particularly applicable to these disease entities. I'm sure you could add to this list. The construct of this payment tactic sets reimbursement based on average cost of treatment. In this case, cost equals reimbursement, not actual cost. In this article by Bach, you can see the various costs of various chemotherapy regimens, once again in non-small cell carcinoma of the lung, and creating an average price. And in the theoretical construct of the article, one could use any of these chemotherapy regimens However, the costs and so forth of the drug would accrue different to not only the provider but the system. Now, let me show you a different version of reference-based pricing that was mentioned yesterday than what was mentioned yesterday. This is a reference-based pricing model from CalPERS, one of the largest purchasers of healthcare in the United States. And what they did is they developed reference pricing, looking at average hospital costs, in this case for joint replacement. They drew that green line to define their reference price by looking at average cost, not comparing to another cost by looking at average cost. And then they went about telling hospitals, this is what we're going to pay you. Those outlying hospitals over at the tail either need to treat these patients at a cheaper cost or drop out of the plan. And finally, let me take a minute, and I'll come back to the ICER methodology to look how this kind of reference pricing could be applied for use in technology-based treatment of prostate cancer. So here was some ICER work done, I think, in about 2008, where they looked at brachytherapy versus proton beam therapy, and they were thought to have similar health benefit, but one, guess which one, had a higher cost. And there was partial confidence around the evidence, at least at the time. So how might an application to pricing of this type of thought process or this type of tactic work? So let's say brachytherapy might be covered. This is theoretical. I presented this slide once and was at a meeting a few years ago and was accosted by radiation oncologists from the floor, telling me that I was doing this awful thing by putting this up here. IMRT might be covered with a copay, and something like proton therapy may not be covered, or covered with a reference pricing methodology, whether it be cost related to IMRT or cost related to something else. I'm going to, in the sake of time, just summarize with my last slide and a few final thoughts. First, just to give you a sense of the context, the conceptual view of value by payers in the United States is dominated by comparative clinical effectiveness and budget impact. And so that CTAF process I showed you embraces that notion. The conceptual view of value by manufacturers in the US is dominated by clinical effectiveness, additional benefits, and the intrinsic value of having multiple treatment options. The best policy that could come out of all of this in the near future might be that payers become more transparent and consistent while focusing more on the balance of long-term benefits of cost in their conception of value. Manufacturers begin to view affordability as a mutual and an immediate imperative, and payment systems take into consideration the cost of evidence development, particularly for technology, because of the particular problems technology development has, and support the process of evidence development. Thank you for your attention, and I look forward to the panel.